Hi, I'm Dr. Joshua Yamamoto, and welcome to this OMED presentation of atrial fibrillation, a useful clinical approach specifically for a primary care audience. It's brought to you in part by the Foxhall Foundation. Foxhall Foundation is a nonprofit organization based in Washington, D.C., dedicated to helping everyone age well. Now, technically, life expectancy in this country has gone down a little bit, but if you factor out COVID and drug overdose deaths, which are important, the remainder of our population is actually aging. We're going to have a big bolus of baby boomers and a rapidly growing population over 65 aging longer than ever before. And navigating that process is important. At the Foundation, we emphasize the notion of building our health for the future. It doesn't just happen, we build it. It's an interactive process, and we understand what happens with aging. And atrial fibrillation is a very big part of that. So the objectives of this talk is to understand that atrial fibrillation is an expected consequence of the natural aging process. It's coming. And to look at atrial fibrillation, and instead of getting lost in all of our questions as we tend to boil it down to three issues. What's the health of your heart? How do we provide symptomatic relief? And how do we prevent strokes? And also, we want to understand how to use all these different pills and procedures, the tools in managing atrial fibrillation, especially from the viewpoint of primary care. Because indeed, primary care is where most of the atrial fibrillation management is going to take place, not necessarily in the office of a cardiologist or a electrophysiologist. Now, a couple of disclosures, as always. I am a paid consultant and speaker for Janssen Pharmaceuticals. And as I mentioned in our other talk, which I encourage everybody to log on and watch, entitled You Can Prevent a Stroke or Stroke Prevention, heart disease isn't really a disease, it's more of just a question of natural aging. The thing is I'm an invasive preventive cardiologist. Invasive in that I do procedures. Preventive, what are we preventing? We're preventing damage to the heart failure, damage to the brain, strokes and vascular dementia, and premature death. And we do that prevention very proactively. Prevent is an active verb. And so it's all about the management of an aging process. So what is that aging process? From a cardiovascular standpoint, there are three things that happen to all of us while we age. The human body. We have 100,000 heartbeats a day. That produces relentless wear and tear, so we have chronic vascular inflammation. Indeed, chronic vascular inflammation is likely the cornerstone of most of our vascular aging processes. In the earlier talk on stroke prevention, we demonstrate with graphic pictures of how inflammation and the healing process leads to atherosclerosis, which is not a disease, but in fact a part of natural aging. And how can we stop that, and how can we prevent atherosclerosis from damaging the heart or the brain? The second thing that happens with natural aging is a loss of elastance, a stiffening of our pipes, a decrease in vascular compliance. We get stiffer arteries. Stiffer arteries mean higher pressure. Higher pressure means more cardiac work, which we'll go over in just a moment. And then the third thing that we take for granted is as we age, we have a decline in sinus node function, a decreased reliability of our natural pacemaker, making the heart slower and more prone to irregularity or atrial fibrillation. Okay, the three things that happen with all of us as we age: chronic vascular inflammation leading to atherosclerosis, a loss of vascular compliance, or what we call hypertensive disease, and a decreased reliability of the natural pacemaker leading to sinus bradycardia and atrial fibrillation. So the atherosclerotic aging we talked about extensively on our program on stroke prevention. But what about the stiffer pipes? Stiffer pipes lead to higher pressure. Higher pressure leads to more cardiac work. Blood pressure is not a disease, it is a number. You need to always interpret pressure in terms of the context of who you're taking the blood pressure on, what's the circumstance, how stiff are their pipes. Male pipes get stiffer starting about the age of 40. In women, the process often doesn't start to the age of 70 or later, and they have a rapid catch-up going from very elastic pipes to very stiff pipes. The thing is the increased cardiac work causes inevitable changes to the heart, which dramatically predispose us to losing electrical stability or having atrial fibrillation. So if you want to know how well we've treated blood pressure, you don't just take numbers. We are not treating numbers, we're treating our patients. And we need to keep their heart healthy. One of the best ways to know how healthy the heart is to examine it. In the 21st century, an examination is not just a stethoscope. I mean, we use a stethoscope, great. I can figure out all sorts of things with a stethoscope, but if I really want to know how the heart works, if I really want to know what has its burden been, you're going to get an echo. An echo is the physical exam of the 21st century, and there's a host of findings that are related to the increased cardiac work. So if you order an echo or get an echo or have echo support in your office, which can be done in primary care, what do we look for? Decreased ventricular compliance. In other words, the ventricle, the left ventricle, will get stiffer. Everyone's left ventricle gets stiffer with time, but hypertension can dramatically accelerate that process. So the report often says things like impaired relaxation, diastolic dysfunction, or what have you. When you read that, what that's telling you is that you have to be mindful of the hypertensive changes to the heart. The change that's most concerning, particularly for atrial fibrillation, is left atrial enlargement. That's a hypertensive change. Notice loss of ventricular compliance comes with time and pressure, not loss of ventricular function. A perfectly normal ejection fraction can still be stiff and have an enlarged left atrium from a chronic pressure load, meaning undertreated high blood pressure. We don't lose left ventricular systolic function with age, but we do lose diastolic compliance. We all get stiffer. You stretch out the left atrium, you get mitral and tricuspid regurgitation. You overwork the left ventricle, the muscle will become thicker, and that's the left ventricular hypertrophy. And eventually you can get elevated pressures within the heart. You'll hear about the right ventricular systolic pressure. In other words, back pressure. All of these are things routinely reported on an echo. But what we don't always tell you when we, the cardiologists, fill out these echo reports, especially since so many of them are computer generated and pre-selected by clicking buttons by the technologist, there isn't the explanation of what it means. What it means is that you have hypertensive changes. You are beginning to have the hypertensive effects on the heart. And all of these things will feed back and give you more left atrial enlargement. The ventricle, in response to pressure as a muscle, will get thicker and stiffer. In response to volume, it'll try to stretch. Pressure loads, volume loads. Either one of those loads will tend to stretch the left atrium. You stretch the left atrium, you're going to stretch out the mitral annulus, and you'll get more mitral regurgitation. Then you have more regurgitation, and you get more left atrial enlargement. So the process feeds back on itself. And what lives in the left atrium? But the conduction system, the confluence of the four pulmonary veins, and that's where atrial fibrillation springs forth. Now, what else happens routinely as we get older? The sinus node ages. We've always known this, that the sinus node ages. It's just not a terribly relevant thing until you are in your 60s, 70s, 80s, 90s, and 100s. Then the aging of the sinus node becomes incredibly important. For my patients, I often describe their heart as a marching band. This is the sinus node, the drum major, calling the tempo, leading the band. The heart follows along when the sinus node, when the drum major tells it to beat, and everybody is in step. That's a regular rhythm. But drum majors do age. We mentioned this in our stroke prevention talk. And as we get older, the sinus node function declines. This is the chart we've seen in every gym we've been looking at for years, and we've known this for a long time. You can quiz a medical student and say, what's the maximum predicted heart rate? And it's a formula empirically observed as 220 minus your age. And you know what? There is only one variable in that formula, age. Sinus node reserve, sinus node function. The ability for the sinus node to accelerate goes down with time. This doesn't mean that your physical activity is necessarily limited, but it does mean that our heart's ability to accelerate is limited. And keep in mind that cardiac output or blood flow is what matters. Our organs need flow. It's not pressure, it's flow. You have to deliver fresh blood with oxygen, nutrients, all that good stuff. And what is flow or cardiac output? Heart rate times stroke volume. And as the heart gets stiffer, the stroke volume becomes more fixed, meaning it's less elastic. So our cardiac output becomes very rate dependent. And if we are slowing down, that means we have impaired flow. And indeed, eventually, that impaired flow, it can be a compensation, if you will, to have atrial fibrillation. To say, well, what happens if the drum major is doing nothing, but we really want to move that band forward? Well, my beautiful alma mater, again, for those who recognize it, without the drum major keeping everybody in line, there can be chaos. But again, chaotic movement can be better than no movement at all. So this is part of our way of wrapping our minds around understanding why atrial fibrillation becomes so common with time and why the health of the sinus node is an incredibly important thing to be mindful of as it predicts people who are going to have atrial fibrillation. Well, how common is it? So here are my fun/scary facts about AFib. When we do long-term monitoring, which I'll describe in a second, if you took a cohort to 70-year-olds asymptomatic, emphasize that, with a history of hypertension, which in fact is most 70-year-olds, because that's also an age-related process, or at least a lot of 70-year-olds, 70% of them have atrial fibrillation. So it's that common. About 1% of 50-year-olds will have atrial fibrillation, 70% of hypertensive 70-year-olds, as many as 40 to 45% of 80-year-olds. And in my patient population, which has a growing number of 100-year-old patients, essentially all of them have at least some atrial fibrillation. Now keep in mind that the vast majority of them are asymptomatic. The authors of these studies like to emphasize that just because you have atrial fibrillation doesn't mean you have a clinical problem, meaning it's a subclinical phenomenon. People don't feel it, but it matters. It matters because we've had data for many years looking at people under observation, typically, for example, with pacemakers. If you have a pacemaker, it will record all of your atrial fibrillation, whether you're aware of it or not. Keep in mind, pacemakers do not prevent atrial fibrillation, although they're a very helpful tool, which we'll get to. But it turns out that as little as 6 minutes, a 6 minutes continuous run of atrial fibrillation will double your risk of a stroke, an ischemic stroke. You ever wonder how hypertension leads to ischemic strokes, clot in the brains? The answer is through atrial fibrillation. It's atrial fibrillation that's so incredibly common. And the biggest issue that concerns, or should concern most of us, is the fact that that drives strokes. We can underperfuse the brain, and we have the opportunity for ischemic strokes. When in atrial fibrillation, the atria is not contracting uniformly and the blood becomes static. Again, the left atrium is the confluence of the 4 pulmonary veins, so it's essentially a low-flow venous stasis. It's basically a DVT of the heart. That's going to be important when we start thinking about how do you prevent the stroke. We know how to treat DVTs. There you go. It's a very similar sort of approach. You have to adequately give stroke prevention, meaning anticoagulation. Atrial fibrillation also causes a lot of variability in pulse waves. So there is small vessel ischemic changes associated with atrial fibrillation as well. Again, differential pulse waves, differential acceleration causes inflammation of small vessels, which can lead to more accelerated inflammatory responses or atherosclerosis. Point is, you need to know you have atrial fibrillation because it takes very little of it before stroke risk elevates. Have some faith, the stroke from AFib doesn't happen the day you have AFib. It's actually quite delayed. On average, 3 to 4 weeks or a month up after you have an episode of atrial fibrillation comes the stroke, which makes sense because it takes time for a clot to form in the appendage of the left atrium, hanging out there, and the clot has to grow big enough and then embolize for the typical stroke related to atrial fibrillation. So we need to think of atrial fibrillation as a natural part of the aging process. And I often tell my patients, really, this is more of a description than a disease. We are describing how does a 75, 80, 85-year-old heart beat. So I tell people all the time, AFib is coming, don't take it personally. You can do everything right, and if you're healthy and live long enough, you're going to have atrial fibrillation. In fact, our competitive athletes who are so bradycardic, when they get into the second half of life, they are much more likely to have atrial fibrillation because their sinus node has been downregulated so much. Bradycardia predicts that. So, what do we do in primary care? Suspect it. Suspect it. Be mindful of it. Anybody who gets old enough, it has to be on your list of things that we're thinking about. They're getting older, they're more and more likely to have atrial fibrillation. If they have a history of high blood pressure, and if you know they have poor sinus node function, well, how would you know their sinus node function? You walk in the door, you have a heart rate of 40, you have high blood pressure, if I can see your echo and you already have a stretched left atrium, you know what? You're 70 years old, you're already having AFib, we just haven't found it. So you need to suspect it. Other things that make it more likely, again, atherosclerotic disease, like coronary disease particularly, can add to the burden on the heart, which can make it much more likely to have atrial fibrillation. And then most of us know that the sleep apnea associated with an obesity with or without sleep apnea, although show me an obese patient without some sleep apnea, increases the drive to atrial fibrillation. Being obese increases the cardiac demand. I often tell my patients it's not the weight, it's the volume. If there's more of us, you have to circulate more. So again, that increases cardiac work. The heart does not like to be overworked, and things that overwork the heart are going to predispose us to having atrial fibrillation, particularly because of the effects on the left atrium. And sleep apnea with the intermittent drops in oxygen levels, that's actually quite toxic to the sinus node. And people have periods of sinus bradycardia and even sinus arrest. And again, that sort of thing also is going to drive up our adrenaline response. And these clearly predispose us to atrial fibrillation. But the substrate is the age and the hypertensive heart and the loss of the sinus node function that goes with aging. In other words, you can be thin as a rail and you can cure sleep apnea and you can have no vascular disease. You're still going to get older. And as you lose sinus node function, you're going to have to think about the likelihood that you're having some atrial fibrillation, even if it's minimally symptomatic or subclinical. So we need to find it. First you suspect it, then you have to find it. Symptoms are really poor predictors of whether or not you actually have atrial fibrillation, and we know they're poor predictors of stroke risk, so you have to look for it. There are a lot of ways of monitoring. Yes, I've been asked, it is true, one of these 4 pictures I modeled for, but I won't say which. There are medical monitors, like placing an ambulatory monitor. This is a great tool. There are many commercially available ambulatory monitors. 24-hour monitoring is kind of a thing of the past because these monitors are quick, they're simple, typically waterproof, comfortable to wear. They range from 1 week to 30 days. In one large study, nobody could comfortably wear it after 11 days because of the skin irritation. I find practically a 1-week monitor gives you about all the useful information you're going to need because it's a continuous monitor. What if you have episodic symptoms? Well, you can use commercially available touch monitors. This is a Cardia or a LiveCore that basically turns your cell phone into an EKG machine. The drawback of a 1-week monitor is that you only get a week of data, but it gives you everything. It's going to show you a lot about the health of the sinus node. Are you persistently bradycardic? Do you occasionally have really low heart rates? Do you have periods of sinus arrest or even pauses? Do you have short little bursts of atrial arrhythmias? Oh, you know, there's a 27-beat run of some atrial tachycardia or paroxysmal AFib. These are all the precursors that tell you AFib is coming, or maybe that it's already here, just not terribly symptomatic or sustained. A spot monitor, hey, you buy it once, you have it for life. It helps a lot if you have an email or portal relationship with your patients so they can send you their EKGs. Because the machine they're trying to avoid responsibility for interpretation, but it's very good at telling normal versus abnormal. The disadvantage is, of course, you're not going to get subclinical information. If you're not feeling a symptom and you don't put your fingers on the device, it's not recording. So the wearable monitors, Apple has sponsored a study trying to look for the prevalence of subclinical atrial fibrillation, these Apple Watches can be set to monitor you all the time. They're good, they're not necessarily great, they're certainly imperfect, but at least it's a step forward so that conceivably if the system is working, it'll give you a little note, hey, did you know you had an irregular heartbeat? And so that's the idea of looking particularly for subclinical events, plus you can use it like you can use other cell phone-based technology to capture an EKG. The best way, when you really want to know, a way that's fundamentally flawless, is an implantable cardiac monitor. These little devices, which really have the same size profile as a paperclip, we can slip under the skin and it records everything. It's very good. It will, and a primary care doctor can do this. There are several manufacturers, Abbott, St. Jude, Medtronic, Guidant, or Boston Scientific, I mean. Each monitor has certain particular advantages and disadvantages. The point is they're really easy to put in. If you know how to infuse lidocaine and can nick the skin, you can put in one of these monitors. It records everything. It can synchronize to a cell phone and then send whoever wants it, like me, a notification if your patient has had excess tachycardia, bradycardia, pauses, or atrial fibrillation, whether they're symptomatic or not. And the monitor battery life is several years. So this is an incredibly useful tool. And I may have mentioned that I put CMS on my disclosures. 95% of my clinical practice is in patients over 65 on Medicare. So most of my revenue stream is from Medicare. And Medicare has authorized this when we suspect atrial fibrillation, particularly with symptomatic palpitations. So it's a very low threshold to get this information. And I have to tell you, during the pandemic years, I can monitor people's EKGs from afar. It was wonderful. Why go to the hospital with palpitations? If I know you have a healthy heart, it's just a question of how are we managing this. So very useful tools. First suspect it, then find it. And finding it is really something in the purview of a primary care practice. You don't have to go to a cardiac electrophysiology to say, oh, find atrial fibrillation. We can do that before that level of referral. So once you find it, then what do we do? Suspect it, find it, then we need to ask 3 questions. What's the health of your heart? And how do we know? How are we managing symptoms? And how are we preventing strokes? What are we doing to prevent a stroke? In the old days, we could get lost in all sorts of, well, am I rate controlling, rhythm controlling, am I curing AFib, what's causing? There are no causes of AFib. AFib is a natural process. There's no curing of AFib, there's managing of AFib. So you ask these 3 questions. And as we go through the diagnostic and therapeutic procedures, it really boils down to what is it that we're addressing? Are we addressing the health of the heart, the symptoms, or stroke prevention? So first question, well, what's the health of your heart? Now this cuts both ways. It's a two-way street. Meaning the more unhealthy a heart is, the more likely you are to have atrial fibrillation. But you can be perfectly healthy, not a thing wrong with you, and have atrial fibrillation as a primary electrical issue. Like I said, athletes and some of our fittest, healthiest people are some of the most likely people to have atrial fibrillation when they get older. And if we do not manage the atrial fibrillation well, it can make the heart unhealthy. So it goes both directions. The atrial fibrillation, we call it a disease. Again, it's a description of how the heart's beating. It can be entirely incidental. It can make a heart unhealthy, but an unhealthy heart is more likely to have AFib. But no matter how you want to muddle that up, we need to have clarity as to what is the health of the heart, and we need to keep the heart healthy. What do you mean keep the heart healthy? Well, in the 21st century, rather than labeling everything with a diagnosis, it's much easier and more useful to think of the processes. What is affecting a heart? And again, this is where primary care is absolutely critical because that's where we manage the processes. Ischemic heart disease, that's atherosclerosis. I'm sorry, in the 21st century, nobody should have atherosclerosis. In the old days, the thing that affected the heart most was valvular disease from rheumatic fever. We don't see rheumatic fever anymore, hardly. Why? Because we have penicillin. There's kind of no excuse not to give a kid with a strep throat to say, let's just, he looks healthy, let's treat this naturally. No, we give them pills. We give them antibiotics, so we don't have rheumatic heart disease. You know what? Ischemic heart disease is a natural aging phenomenon that can be stopped with statin therapy. So but if you have ischemic heart disease, because we inherit an older population that didn't have or know to use statins, fine, but understand the health of the heart. The one that matters a lot is hypertensive disease, because again, that tends to be entirely asymptomatic. We overfixate on numbers without understanding or thinking of the process. Are you overworking the heart? Don't come and tell me, oh, I just have white coat hypertension. I'm going to look at your heart, and if you have hypertensive changes, then apparently you're seeing white coats all the time. And it's an aging phenomenon, so know whether we have hypertensive disease, the blood pressure related overworking of the heart, because that's the one that really drives us to AFib. Valvular disease is both easy and complicated. Easy to diagnose, that's why we have ultrasound. You do not have to rely on your stethoscope, just get an ultrasound. Keep in mind the aortic valve is part of the aorta, the mitral valve is part of the left ventricle. This is not a treatise on treating valvular disease, but it's not just a label. It has to be understood, especially the mitral valve. All this mitral regurgitation, a lot of it is the reflection of the health of the heart. Why does that matter? Because valvular disease is another thing that creates a burden on the left atrium and traditionally is the major driver of atrial fibrillation. Just understand it. Know what you're dealing with and know if it's a primary or secondary thing. Conduction disease. This is age. Okay. Know the health of your heart. If your heart doesn't have a reliable electrical system, that can cause its primary set of problems. There are primary myocardial diseases, infiltrative processes and which not. They're less common. And the only one that's relevant in a primary care setting is diabetes. Now, diabetes drives ischemic disease. Okay, nothing speeds up plaque growth more than diabetes, but it is true that diabetes can lead to direct trouble with the heart muscle itself. So we want to treat the diabetes. Ask the question about the health of the heart. Who's driving the bus? What's the responsible processing, okay? Is the heart unhealthy and the AFib incidental, or is the AFib what's making the heart unhealthy? And this is where we often get lost. What's the health of the heart? And what are the processes that we can do to keep the heart healthy? And most of this is going to be done by primary care. Your cardiologists are going to send this back to primary care and say, handle risk factors. They're not risk factors. These are the things that accelerate natural aging. Diabetes is number one by a long shot on the list. Smoking. Yeah, we know, don't smoke, great. That's a primary care job to help our patients stop smoking. Hypertensive changes, lipid management. Lipid management is way less important than we once thought. Treatment to prevent plaque buildup is hugely important, but you can have normal cholesterol and we're still going to need to have you on statin therapy once you have plaque buildup. And remember that the vast majority of atrial fibrillation is subclinical. But it is absolutely true that even healthy people with primary electrical trouble, meaning that's what's driving the bus, AFib, can lead or push somebody over the edge to heart failure. Again, heart failure is a term I don't like. It's about as specific as your auto mechanic telling you, oh, you have engine trouble. That doesn't help me. I know I have engine trouble. I need to know why so I can better management. Who's driving the bus? The AFib may be incidental. Question one. Okay, I suspected AFib. I found AFib. Now I'm asking three questions. What's the health of the heart? You likely can enroll the help of your friendly neighborhood cardiologist to help you understand the health of somebody's heart. But you see, if you get distracted by the AFib, oh, we've got to limit the AFib. No, you don't. Our current Medicare database suggests that 6 to 7 million Americans are in permanent atrial fibrillation already. You can live to be 110 in permanent atrial fibrillation. So if that's not what's making you unhealthy, you don't have to go out and cure the AFib. It's just something you need to be managed. We can't allow the AFib to contribute to making you unhealthy. And if it is making you unhealthy, what I mean by that is a heart that's not doing its job well enough, so that's heart failure. Your heart's not doing its job well enough. Well, what's causing that? Who's driving this bus? Is it because you're too fast? If you have a heart rate over about 110 beats a minute chronically, you're going to end up dilating the heart and having heart failure. Is it too slow? We often forget, slow is not helpful. You see, if you have a heart rate of 0, you're dead. If you have a heart rate of 20, you're almost dead. If you have a heart rate of 40, you're either close to being dead or you're an Olympic athlete. Context matters. And if you're too slow, again, that can create an enormous burden on the heart to maintain cardiac output. If you're trying to circulate more, you're supposed to beat harder and beat faster. And if you can't beat faster, all you can do is beat harder. So don't forget, bradycardia in our older population can create an enormous strain on the heart. Other things, too much irregularity, beat-to-beat irregularity can really impact cardiac output. And the loss of the lub-dub, the atrioventricular synchrony. The atrial contraction does contribute to the cardiac output. The older we get, the less important the atrial contraction. So two people with the exact same left ventricular ejection fraction and with the same rate can have vastly different cardiac outputs depending on whether or not they have an atrial contraction and how stiff their ventricle is. So that loss of atrial contraction and the loss of the atrioventricular synchrony, the point is there are a lot of things that can decrease cardiac output or strain the heart related to the atrial fibrillation. It's not just one thing, which is why there's not ever just one answer. And trying to make the AFib go away is not always the answer, because you can still be way too slow or way too irregular just from atrial beats to have a good cardiac output. So you have to look at the person and the heart as a whole. Again, understand the health of the heart. And yes, you may need the help of a cardiologist with that, but we'll get to that because cardiologists sometimes are not as helpful as we need them to be. Question 2. Okay, I am doing whatever it takes to keep your heart healthy. Treating ischemic disease, treating hypertensive disease, making sure you don't have valvular disease, addressing your conduction system. I'm keeping your heart healthy. Fine. You don't have heart failure. Question 2, what symptoms are you having? Because remember, 90% of folks with atrial fibrillation are asymptomatic. If you're asymptomatic, how am I going to make you feel better? We like to say that everything in medicine we do is to help you either live longer or feel better. Atrial fibrillation doesn't have to make you live any less. And if you're asymptomatic, what exactly am I treating here? So what are your symptoms? So I like to think of the universal symptoms of a heart that's less efficient. Fatigue, exercise intolerance, breathless. Are you feeling dizzy or lightheaded? Palpitations. I'm not exactly sure what a palpitation is, but it's a great excuse to explore the heart. Anyway, all of these are the universal symptoms of a heart that's less efficient or not beating or circulating the way we'd like it to. But if you want to focus on the symptoms, it's good to try to understand what's driving the symptoms. Are you feeling it because you have bursts that are too fast or you're consistently too fast? Are you feeling it because you're too slow or occasionally too slow? A lot of times you see somebody in the office, their EKG's AFib, but the rate looks fine, 70 beats a minute, and they feel there, but I'm a little tired, or I'm feeling just, the great brain fog. And you put a monitor on them, and lo and behold, they may be having hundreds or thousands of pauses. Oh, you went 2.5 seconds without a heartbeat. Technically, if you look it up, you don't have to give someone a pacemaker for 1 2.5 second pause, but if you're having thousands of them, you know what? You're just not circulating blood to the brain, and that may be making you tired. That type of irregularity may be intolerable. Like I said, even with a normal rate, the loss of your atrial contraction and atrioventricular synchrony is enough to make a lot of people feel awful. You can have exercise intolerance in particular. The combination of a hypertensive heart and loss of your atrial contraction really can decrease cardiac output. And you may only feel that when you're trying to be active. I'm walking upstairs and I get winded. Well, what happens when you walk upstairs? This is why we look at the heart so much. Who's driving the bus? Try to identify what the symptoms are. By and large, when you're dealing with symptoms, the better we understand it, the easier it is to address. And I love cardiology because fundamentally we're not a terribly complicated organ. It's a pump. If things are too fast, we slow it down. If things are too slow, we speed it up. If things are too irregular, we try to restore regularity. If you have ischemic heart disease, fine, that's a problem. We can address that. Just because somebody has a fast EKG doesn't necessarily mean they're even going to be symptomatic, let alone ischemic. In the hospital, people get excited. Oh, you had a heart rate of 180. You know what? You monitor people over time. You find out they do that all the time. No, it's not a good idea. And if you're consistently that tachycardic, I've seen people with heart rates of 150 beats a minute for 3 months before they bothered to come in and get checked. Because after 3 months, they finally started to dilate their heart and have heart failure from poor ejection fraction, poor cardiac output. But one burst of, when I go sprinting, my heart goes that fast. So the number isn't what needs to worry about. If you have an unhealthy heart and you have ischemic heart disease and you suddenly go 180 beats a minute, well, we wouldn't ask somebody with ischemic heart disease to go sprinting. But if you have a healthy heart, just because it's fast doesn't mean that it's going to hurt you, and it doesn't mean that you're even going to be symptomatic. So it's good to understand the symptoms and how they relate to what the heart's doing. And again, this is where those monitors come in so handy. Wear a monitor for a week, wear a monitor for years, put it under the skin, and correlate what's going on. Because it may be that modest slowing. The issue is we end up with what we call the tachybrady phenomenon, where at times you're too fast and we're compelled to slow you down, but then the rest of the time you're too slow and you feel miserable. That's actually pretty easy to help. It's called a pacemaker. Now, question 1, what's the health of your heart? Question 2, what are your symptoms? Question 3, what are we doing to prevent a stroke? This, in fact, is in some ways the easiest question to address, because for every patient we ask, what am I doing to prevent a stroke? It is a positive question. Don't tell me what you're not doing. Answer that question. What am I doing to prevent a stroke? All these risk factor scorings and things like the CHADS-VASC or CHADS score, they're a little bit disingenuous because they presume that the default is to do nothing. And that is 1900s mentality. In the 21st century, our default should be, what is our best possible stroke prevention? We can wind back or make changes, but you start off with what's best possible stroke prevention. Because remember, a stroke is permanent brain damage from a clot. Brain damage from a clot. And we die from clotting. We don't die from bleeding. We may have evolved to clot well. Why? Because cave dwellers died of bleeding, not clotting. But you know what? We're not cave dwellers anymore. We're not dying of bleeding and infections and malnutrition. We've genetically evolved to clot with great efficiency. And when you have venous stasis, particularly in the left atrium, it's going to clot. It's supposed to. And so we have to prevent it. Do not make assumptions about what our patients want. Most of my patients tell me the thing they don't want the most. They say, look, you know, I'm 85 years old, I'm 95 years old, I get it, I'm going to die someday, that doesn't bother me. I do not want to be permanently disabled. I do not want to have a stroke. I do not want to have vascular brain damage. I do not want to have vascular dementia. I do not want to lose my independence. I don't want to have to rely on my children, heavens forbid. So don't assume that patients are more afraid of a nosebleed than permanent brain damage. And keep in mind that 6 minutes of atrial fibrillation will double your stroke risk. So you start off with a presumption of best possible stroke prevention. So if you have AFib, by and large, your best possible stroke prevention is anticoagulation. There are at least 4 of the direct oral anticoagulants, the 10A inhibitors or the thrombin inhibitors on the market right now. Most people are on either apixaban or rivaroxaban. They are very effective if dosed appropriately, which is important to keep in mind. Be mindful of our tendency to underdose agents, because if you are dosing to have a placebo bleeding effect, you're also going to get a placebo efficacy effect. There's no free lunch. There's no free lunch. We are preventing clotting. You prevent clot, you're going to encourage some bleeding. That's okay, because you're not going to die or have brain damage from the bleeding. Remember, hemorrhagic strokes are rare and they're almost all secondary to prior ischemic strokes. So prevent that ischemic stroke first. Now, if you need to consider something other than a pill, okay, there are mechanical alternatives. You can occlude the left atrial appendage. We'll get to that. But this is a stroke prevention strategy. It doesn't cure the AFib. Remember, that's an irrelevant term. Stroke prevention. Surgical ligation is a nice thing. If you're in the surgeons do this all the time now. If you're in the chest for whatever reason, oh, you needed bypass surgery because we never gave you a statin, they will cut off the left atrial appendage while they're there. Nice and effective. Keep in mind that these procedures still, we usually recommend aspirin therapy. Rhythm control. Oh, what if I cure the AFib? We've tried that. Rhythm control typically does not prevent strokes. Why? Because we're imperfect. And so you don't rely on rhythm control for stroke prevention, meaning we eliminated the AFib, we went back just to sinus rhythm or atrial pacing, unless you know that you've completely suppressed the atrial fibrillation. That means you have to do continuous cardiac monitoring, which is an option. If you think back to the little microchip we can put in, we can know if your AFib burden is 0. That is a knowable thing. So if you're going to rely strictly on the rhythm control and the prevention of AFib for your stroke prevention without direct stroke preventing medications, you need to confirm that there's no AFib. But we can do that. Stroke prevention. Remember, the clot forms in the left atrial appendage. That makes it a DVT of the heart. That's venous flow that embolizes. As I said, it can also be related to in situ arterial thrombosis. So stroke prevention is the third, and in my opinion, most important question. Why is that the most important question? We're always going to ask about the health of the heart. That's our job. That's called taking care of people as they get over 50, 60, 70, 80. We want them to have a healthy heart. Symptoms, our patients will bring us symptoms. I don't have to go out of my way to think about that. It's the strokes that cause such a problem with vascular brain injury. Because prevent is an active verb, you have to go out and prevent the stroke. So medications are your best possible stroke prevention. Aspirin or antiplatelet agents, they're really not effective for the venous thrombosis, which is why they are not our best choice if you have AFib. Apixaban, outstanding medication for atrial fibrillation. Be mindful to not underdose it. It has to be taken BID, and the dosing gets a little vague as you start to get older or you have to weight adjust it. Also, apixaban's not been studied for arterial disease. So that is one advantage of rivaroxaban, which is effective both for stroke prevention with a high arterial plaque burden, and it's an effective treatment for DVTs, as is apixaban, meaning you can use it quite effectively for stroke prevention. It's not lost in adipose, so it doesn't matter about the BMI. So treating AFib, what are we treating? Ask yourself, is this treatment for the health of the heart? Is this treatment for symptoms? Or is this a treatment for stroke prevention? People always talk about, well, how do you treat AFib? Well, what is it that you're treating? So try to have some clarity. Okay, so let's get into some of the treatments. Medications for rate. Why do you control rate? Controlling rate may contribute a lot to keeping the heart healthy. Remember, sustained tachycardia will wear down the heart and can dilate the ventricle. You certainly may be treating symptoms. Not everybody feels tachycardia, but many people do. So rate control. It's not a strategy in its entirety, but it's something that can be necessary to maintain the health of the heart and desirable for the maintenance of or the treatment of symptoms. So the most common rate controlling agents are beta blockers. Diltiazem is the only useful calcium blocker for atrial fibrillation. These are generic medications that have been around a long time, historically used for blood pressure, which again, that can be a problem, right? Because I may need to give you enough of these medications to control rate, but I don't want to lower your blood pressure too much. Digoxin is an underutilized medication for controlling rate. The trouble is, as we get older, the clearance becomes impaired. So I tend to only give folks digoxin that are older if they have a pacemaker. Marvelous. Oh, what about DIG toxicity? Digoxin toxicity means AV nodal blockade, which is exactly what I want. If you're paced, I'm not worried about how much AV nodal block you have. I kind of want you to have AV nodal block. That's what we're doing with rate control, is blocking the AV node. But again, most people on average require some amount of multiple medications, and it can be more effective to use 2 medications in low dose than 1 in a high dose for synergy with rate control. But you have to be mindful of the bradycardia. I'm actually much more worried about bradycardia than tachycardia, assuming we haven't allowed you to have ischemic heart disease, right? There's no excuse for that. But anyway, assuming you don't have inducible angina from AFib, going fast might make you feel dizzy and breathless. But if you have 3 to 4 seconds of asystole because you have a pause, because we've overblocked your AV node, you can go to ground, meaning you can have unprovoked syncope. And not circulating blood to the brain is kind of a bad thing over time. Like I said, you can have hundreds of 2.5, 3 second pauses and may not be aware of the discrete event, but cumulatively, you're not getting blood to the brain. All right, what about rhythm control? Rhythm control was really popular, and then it was unpopular, and then it was popular again. It used to be really popular because it seemed to cure the problem. But we suddenly noticed that most of our antiarrhythmics have a way of killing people, so it became less popular. And you can go back in time and look at the classic Affirm study looking at rate versus rhythm control, and there is a tendency to worse outcomes with rhythm control. But this was using older school ideas and underestimating the importance of stroke prevention. So why control rhythms at all? It does tend to make people less symptomatic. Rhythm control is mostly about treating symptoms. It may make a heart healthier if the irregularity of the AFib is really what's driving a heart to become unhealthy, to dilate the heart or lead to heart failure. But we have to be honest that rhythm control is mostly about symptoms. So a lot of times the treatment may be worse than the problem. So the problem with the there's a lot of problems. The most commonly used ones are perhaps propafenone, dronedarone, amiodarone, flecainide. There are others, but all of these things have some drawbacks. They can be quite intolerable in older patients. They're hard to take, cause a lot of nausea. They can be toxic. Amiodarone is largely iodine. It's going to build up in organs. Everybody's going to have thyroid disorders. They're profoundly sun sensitive. So if you're from Florida, be very careful giving people amiodarone. And guess what? Some of these lead to sudden death. I have a real problem giving somebody a medication that's so risky I have to put them in the hospital to initiate it. And I'm going to give you a 7% risk of sudden death to treat something that's not going to kill you. So most cardiologists are now really backing away from medical the use of antiarrhythmic medications, although they still have a place. And remember, keeping somebody in a regular rhythm, by and large, is about symptoms. So instead of antiarrhythmics, the treatment of choice these days is often ablation. We can go in there and kind of isolate the pulmonary veins, which is where the AFib always seems to start. It's true that in people who have heart failure that's really from the atrial fibrillation, not just lack of rate control, that ablation does tend to produce better outcomes. And if you're having surgery, doing procedures while you're there to isolate the pulmonary veins does give us superior outcomes. But ablation for the sake of ablation, it's kind of like stenting for the sake of stenting. When stents came out, we thought everybody should have an open artery, right? Doesn't that sound good? So if you're partially blocked, let's put in a stent. And it turns out that probably wasn't all that helpful. So we have to be mindful about the utilization of ablations. I show this is a Brockenbauer needle. If we show this to patients, they'd really think a little bit about ablations. You take a needle that's almost 3 feet long, a needle, mind you, stick it up your groin so we can pop a hole from the right, we go from the femoral vein up into the right atrium, punch a hole into the left atrium. So everybody comes out there with an atrial septal defect, right? We create one, slide the sheath across so that we can get our catheters out into the left atrium. I always am very thoughtful before I would stick a 3-foot needle into my groin, but we can do this safely and effectively. You just need to understand what we're doing it for. Pacemakers. I have a bias. I have a lot of older patients, and I think we dramatically underutilize pacemakers. It's not very hard to put one in these days. They're small, it's a little incision. I tend to do the procedure entirely under local anesthesia. Don't even require sedation. We have more complications from sedation than from pacemakers. Why doing it? Because you can pace both the atria and the ventricle so you can restore sinus node function. Now it's an atrial paced rhythm. In the old days, we used to think of pacemakers as a rescue out of desperation to keep people from fainting. In the 21st century, an older patient, the lack of good sinus node function is such a major driver of the unhealth of a heart and of symptoms that if you can restore and control sinus node function, it's a lot easier to maintain the health of the heart. You have ischemic disease, you need a beta blocker, have all the beta blocker you want with whatever heart rate you need. I have patients sick in the hospital. If they're too bradycardic, their cardiac output is too low, that can be a problem. Yeah, I can turn that up with a pacemaker. It lets you maintain atrioventricular synchrony for a long time, use all the medications you need for rate or rhythm control for that matter, and it lets you control and manipulate cardiac output. And you know what? It's not mutually exclusive from having an ablation. You can have a pacemaker and an ablation. You don't have to ablate the AV node. That's another common misconception. Oh, if you're going to pace and ablate, they talk about burning out the AV. Why? You can leave the AV node intact, leave it alone. You can use medications to control the rate, because guess what? You're also treating their blood pressure and promoting the health of the ventricle. The point being, if the lack of a sinus node is what's driving the bus, replace the sinus node. No one said cardiology actually had to be that complicated. If you're getting older, loss of sinus node function is a part of aging, and if that's what's causing your trouble, fix it. A pacemaker is way less invasive than an ablation. So if there's inadequate sinus node health, then you can get a dual chamber pacemaker, the atria and the ventricle. That's a standard pacemaker. And they're MRI compatible now. Stop worrying about that. MRIs never affected pacemakers to begin with. We're not morons. We didn't build them out of iron. They don't rip out of your chest. So don't worry about that sort of thing. They help you do more, not less. And if you're wondering again about ablation versus pacemakers, you can have both. There are these new fancy things. This is a picture of an intracardiac pacemaker, leadless. So I can just screw this thing into your right ventricle if I want. Now the trouble with that, of course, is there's not yet the technology to pace the atrium and the ventricle and keep them synchronous. But if you have permanent AFib, this is a little device that we can actually pace your ventricle. Lets us block your AV node all you want. There's no leads to cause trouble. So these are becoming more popular in our patients with permanent atrial fibrillation. They're supposed to last a decade. The batteries may last longer, but again, nobody knows what the real world is until you're in the real world. But these have a place. The downside is that the delivery system, the catheter, is actually kind of huge. So if you're a smaller, more petite, older person who doesn't have robust circulation, it's not always easy to do. But it's out there, just so you can say you've seen it. Because your patients may ask, hey, I heard there's a fancy no-lead pacemaker. Yeah, if you need sinus node support, it's not for you. It's only if you have permanent atrial fibrillation. Oh, and I heard there's a procedure to keep me from having a stroke. That's the left atrial appendage occlusion devices. The most common one is the Watchman. It's this thing that you can imagine collapses down, springs open, and occludes the left atrial appendage, which is this little sac that sits off the left atrium. Maybe I should have showed a picture, but there's a blind sac off the left atrium. It's some embryologic remnant, and that's where the clots like to form. And so the idea was you could put one of these things in and preclude the use of anticoagulation. However, it still has a certain degree of thrombogenicity, so we still like to give it with aspirin therapy. And it's important to remember that aspirin therapy has the same bleeding rate as low-dose apixaban and low-dose rivaroxaban. Granted, low-dose apixaban and rivaroxaban may not be adequate stroke prevention for AFib. So it's not a free ride. It can be a very useful procedure in folks who really can't be anticoagulated because of incessant, untreatable hemorrhaging, like small bowel arteriovenous malformations that you just can't ever track down, but you're going to have to decide whether they can tolerate aspirin. So again, that's what that procedure is. So people will say, oh, I want a Watchman to treat my AFib. You're not treating the AFib, you're preventing strokes. You're still going to have all the AFib you want. Okay. So it is yet another effective tool. So wrapping things up, what's a primary care physician to do with atrial fibrillation? You need to know your cardiologist that you work with, because there are going to be tools that the cardiologist is going to do. And I say know your cardiologist. For better or for worse, 10 to 15 years ago, 95% of cardiologists were in private practice or in physician-owned practices. Today, and only about 5% of cardiologists were institutional. Today, that has entirely reversed, and almost all of the cardiologists in this country are now institutional employees. So if you're an employee, you are driven by the needs of your employers. And guess what? Procedures are what pay the bills. So some cardiologists are unavoidably driven to be asked the question, like a surgeon, do you need a procedure? That's not wrong, but you may not ask your friendly neighborhood surgeon for help evaluating something or managing something over time. We need our procedural doctors to do procedures, but the chronic evaluation is something that's going to be done in the primary care arena. Your cardiologist may be able to help you with imaging. I'm a huge advocate of ultrasound as the modern physical exam to understand a heart health or vascular health. You don't have to be able to interpret those images yourself. A cardiologist can do that, and we can do that remotely. You just need the technologist to bring you the procedure and to understand what questions you're trying to answer. What's the health of the heart? Do they have progressive hypertensive disease? Have they lost systolic function? How big is the atria? So these are really useful things which a primary care doctor can do in their office. And know that electrophysiologists, the subset of cardiology, oh, they're the AFib experts. They're not there to diagnose AFib. They're not there to manage AFib. They're there to do procedures. It takes too much time and training. If you go to an electrophysiologist, again, it's like a surgical consult. I put in pacemakers. I'm not an electrophysiologist. Most cardiologists now are a little more specialized. But if you think it's time for an ablation or time for a device, that's a great time to see an electrophysiologist. That being said, some specialists are just brilliant at the long-term management. So know who you're working with, and you're allowed to work with more than one doctor. And perhaps most importantly, know our patients. If you're in primary care, understand that natural aging is a process. Again, atherosclerosis from vascular inflammation, stiffer arteries and pressure changes, and loss of sinus node. So know your patient. Over time, atrial fibrillation becomes common. Look for it. Understand that you have to be the one to find the atrial fibrillation. Monitor, medical monitor, meaning the wearable ambulatory cardiac monitors or the implanted monitors. Again, contact your local device reps. If you're interested in putting in monitors, you talk to your cardiologist who put in pacemakers. They'll get you connected with the people that can make that happen. Working with the patient's personal monitors, not the health trackers. I kind of don't care how much you walked today or what your sleep cycle was or what your mood reading tells you. I need to know if you have AFib. Okay, so the Cardia monitor and the Apple Watch are commercially available monitors, and there are other variations and many more in the pipeline. Suspect AFib, look for AFib, and once you find it, ask what's the health of the heart. You may need a cardiologist to help you with that. What are your symptoms? That's something that a primary care doctor is going to be keen on, and this one is the one that really people all seem to think it's somebody else's job, but what are we doing to prevent a stroke? And it's primary care doctors and providers always have the right to captain the ship to say, this patient needs the following. How are we preventing stroke? Work with your cardiologist. How do you know the health of a heart? An echo, an exercise. I do an echo and an exercise echo on virtually every patient. I want to know how the heart works. I want to know how it works when you're sitting still and what the cumulative changes are. And I want to know what you're doing when you try to exercise. Pharmacologic stress, CAT scans, yeah, whatever. They give me information. But if you feel bad while you're up and walking, I need to see what happens when you're up and walking. If you can walk, you can have an exercise echo. But you have to understand what questions you're asking. Look at the process. Do you have hypertensive or ischemic disease and other health issues that are related? Again, this is all about primary care. Do you have sleep apnea? A cardiologist isn't going to help you with that. Do you have a thyroid disorder or other metabolic issues that can all contribute to triggering or driving more atrial fibrillation? And the symptoms. If you're having symptoms, who's driving that bus? Is it too fast, too slow, too irregular? So understanding the symptoms lets you work with your cardiologist to say, hey, I think this guy needs a pacemaker. They're weak and dizzy all the time, and his heart rate's only 40. Shouldn't be that hard, but a lot of people really wait too long. And they chronically underperfuse the brain and wonder why they have vascular dementia that was entirely preventable if they had a reliable heart rate. And the AFib goes right along with that. Nobody knows patients better than their primary care provider. And also, what are we doing to prevent a stroke? Best possible stroke prevention, which means direct oral anticoagulant. Notice I never even mentioned rat poison. I'm not going there. Go watch my other talk on stroke prevention. If you're using rat poison for stroke prevention in AFib, it's close to malpractice at this point. It's the 21st century. There are some exceptions, fine. Left atrial occlusion devices have a role, but it's not typically the first thing we do. Final messages. None of us, no one is immune from aging, and atrial fibrillation is common, if not potentially inevitable, if we live long enough. We don't know our health on the inside unless we look, but you can look, it's not hard. Symptoms do not predict risk, particularly stroke and brain damage. We have to ask, after we find the AFib, what's your health, what are your symptoms, and how are we preventing stroke? Preventing a stroke, because prevent is an active verb. So, the Foxhall Foundation put out this book. All proceeds go to support the foundation at foxhallfoundation.org. You can prevent a stroke. I encourage you to watch the accompanying lecture on stroke prevention, and you can check out our website and get this book. There are 2 chapters in it, all about atrial fibrillation. One is AFib is coming, don't take it personally. And the other is, so I have AFib, now I've got to deal with it. So, thank you very much, and thank you for your time.